Hello everyone, my name is Belle. Today I'm going to do a presentation about ethics. And the case study I want to talk about is end-of-life ethical issues at the intensive care units. Firstly, I will go through the definition of ethics. Ethics is a branch of philosophy that used to study ideal human behavior and ideal way of being. It's a systematic approach to understanding, analyzing, and distinguishing the matters of right and wrong, good and bad. Ethics is the study of morality. It involves careful and systematic reflection on the moral decisions and behavior, which helps achieving a correct analysis of the situations. Therefore, ethics is a matter of knowing, whereas morality is a matter of doing. Ethics provide rational criteria for people to decide whether to behave in some ways rather than others. It may not be associated with learning and life experience. Simply speaking, morals are unarguable, but ethics has always been debatable. In this case study, I will focus on the nursing team. Nurses in general have to face lots of ethical issues, regardless of which ward they are in. For example, during a disaster, the decision to advocate for the sickest patient is usually overruled by the utilitarian principle, which means the greatest good for the greatest number of patients. So they focus on the basic good of survival for the greatest number possible. Other issues when a cardiac arrest occur, in many cases, resuscitation continues without asking the family or relative of the patient's wishes, whether they want it or not. In emergency care, the basic principle of ethical autonomy are frequently ignored because the patient has not been informed about the treatment, even when he or she is able to make the decision independent of the situation. Because in the emergency care, the decision is perceived by the factors such as time, unable to assess, unconsciousness, absence of family, and life-threatening situations. Other common issues such as stopping treatment is the right thing to do when there is no hope for recovery, or why should the ICU withholding or withdrawing the treatment. When it comes to ethics, there is a guideline about ethical practice for nurses. Typically, nurses value the quality nursing care for all people, respect the individual ethical values and as well as human rights, spiritual beliefs, appreciate the differences about cultural backgrounds and languages. The patient's health and well-being is always their priority, necessarily to detect and prevent adverse events in the healthcare settings, maximize the patient's health outcome, and minimize the unwanted harms. Nurses also value the legal and moral right of people, including children, to participate whenever possible in the decision-making concerning their health care and treatment, assist them to determine their care on the basic informed decision-making. The nurse has to ensure that the individual receives the accurate, non-judgmental, sufficient, and timely information in a culturally appropriate manner to permit informed consent for care and related treatment. Next, this case study I want to discuss today is in this ICU settings. Given a case study of Tom, 38-year-old man, who stayed for colorectal cancer, he was sent to the ICU with dehydration and acute renal failure, following a fourth cycle of savage chemotherapy. History of surgical resection at the time of diagnosis 3 years ago, radiation therapy, and multiple courses of chemotherapy. Over the past 36 hours, he had become acutely ill with anorexia, nausea, and vomiting, and altered mental state as well. Requires vessel pressure support, intravenous antibiotics, and bilevel positive airway pressure support. His oncologist reports in his admission is that Tom has not tolerated the savage therapy well, therefore his performance has become worsening. He has a wife with 3 kids and they wanted everything done to save him. Next 24 hours, he continued to decline. He attempts to wake up and communicate but is very lethargic and agitated. He is unstable and requires blood transfusion. The ICU nurse requests a palliative care consult to help support the family and make them understand that Tom is dying. Family meeting was held to review current status, but there's poor prognosis for survival. Therefore, the recommendation to shift to the comfort-directed care. It has been determined that none of Tom's conditions are reversible and his decline is due to the progression of his terminal cancer. But his wife wants to keep Tom a Phuong blue and reports Tom told her to always do everything she can to keep Tom alive for their kids. She shares that Tom has been told by his oncologist that he is terminally ill, and the oncologist has recommended hospital to him several times, but Tom refused. Therefore, the wife feels that it is Tom's wish that they should do anything to keep him alive. After 5 days, Tom continued to decline overall. The responsive requiring increasing vasodilation support, and he has been intubated. The staff was not happy that the wife disagreed to shift his goal of treatment to comfort before he's really dying, despite the medical team advices. This caused the reluctant staffs who were assigned to him because they feel like they're inflicting harms to him. During the night shift of day 5th, Tom goes into the cardiac arrest, Bronte and cold blue, Chaplain and child nurses are with the wife and keep them updated and supported. Then the physician comes to tell her he wishes to cease the attempts at resuscitation because Tom is not responding, and the wives agree. Then Tom passed away after that. The wife states to the nurse that she feels comfortable that she followed his wishes and give him every chance to live. But the staff are very angry because they said that the wife put Tom through that. They express all of his sadness and frustration. So the ethical concern is raised here is that according to the nursing and medical literature, most patients with advanced illness say that they would want to die at home in the presence of family and with the focus on their comfort. The thing is, when facing a situation when patients are at their terminal state of illness and want to keep fighting for prolonging life, then we have to go through a very aggressive treatment. The ICU nurses specifically are faced with a lot of challenges of maintaining treatment delivery and providing honest communication and emotional support to the family. The parties involved in this case are healthcare providers such as physician, oncologist, ICU nurse, medical team, consultants, patients, the patient family. However, ethical principle must only be applied within the patient's personal context. In this case, talk about autonomy. The medical team places more weight on the patient wishes than that of the ethical principle. Since the literature is clear that the likelihood of benefit of CPR in Tom's case was very low, and also with high risk of increasing harm, they could say that this treatment would be non-beneficial for Tom. In case that with important decisions, the physician will certainly come to consensus opinion when he or she recognizes how deeply personal these decisions are and choose to support the patient's wishes, even if he or she disagree. But when the consensus cannot be reached, the ethics committee consultant can help to evaluate the case, determine the medical standard of care, and support physician decisions, or make alternative recommendations. And again, in this case, the ethics committee was not available, so the decisions had to be made between the healthcare team and the patient's family. Next is the beneficence. According to the ethical principle demand, the medical team must always act in the best interest of the patient. And in this case, the nurses didn't feel the prolonging aggressive medical intervention were in the best interest of Tom due to his terminal illness. Therefore, they feel it would create suffering for him at the end of his life. But it's important to note that life-prolonging medical treatments such as CPR, defibrillation, intubation with mechanical ventilation are ethically neutral, which means independently they are neither good or bad. It is depend on the context of the particular patient scenario so that we can define these treatments as either beneficial or harmful. So next is non-maleficence. It's clear that the nurse felt they were harming Tom by continuing to pursue life-prolonging treatment, not only by potentially injury but also not facilitating a more peaceful, dignified death for him. If after receiving full information and knowledge from the medical team, the family still want to continue the treatment that is still being offered. However, it's hard for the nurse who has to perform the chest compression when the patient occurs. So they need to communicate with his or her supervisor to get the patient can be assigned to another nurse because they feel doing this to the patient is not ethical. But there is no universally accepted definition of a good death to follow. However, many articles have explored some definition of this topic and describe a good death based on pain and symptom management, clear decision making, preparation for death, cognition, contributing to other information of the whole person. However, at the end of the day, what becomes clear is that the patient perception of a good death is deeply personal and is influenced by the cultural and spiritual belief as well as the past experience with loss. Importantly, patients do not defy and apply reference in the same way with others such as nurse or doctors. So when it's driving the conflicts for nurses, the nurse should take a step back, reflect and accept that the definition of a good death is personal and it's not for the nurse to choose whether or not the patient died in the way the nurses think they should. Finally is justice. This refers to the need to protect vulnerable population and observe fair allocation of medical resources, which means this is a real issue with a significant ramification for our society. In this case, one could argue that is it perhaps injustice in the prolonged use of the ICU bed and increased cost of aggressive care that would not change the outcome. However, the concentration is on the patient and family goals, and if their goals is to pursue life-prolonging measures, then that level of care is provided regardless of the cost. But this type of decisions should be made at the state or national level, not at the bedside. I believe that in this case, the nurses should build a therapeutic relationship with the family to be trust with them in order to facilitate the goals of care discussion. There's many recommendations for these kinds of ethical issues, such as palliative care principles should be applied in the ICU settings. These are skills and competencies that all physicians and healthcare providers should acquire. It includes discussion and education with special training about goals of care, formal consultation, and management of distressing symptoms. Nurses should spend time to explore the old fear of death, work through their feelings, and in order to be engaged with terminally ill patients, and need to engage in self-care strategy as well, such as exercise, spend quality time with the loved one, so they to avoid being burnt out. Education strategies to help close the gap in their knowledge of workplace policy. These include continuing education, case-based discussions, and knowledge translation that allow policies to be easily comprehensible. Importantly, recommendations were made for staff to have a participatory role in the policy-making process as well. Last but not least, educate all the team members on appropriate behavior defined by the organization code of conduct. Assess staff perception of disruptive behavior and threat to patient safety. Thank you for watching.